Good morning, everyone. At the outset, I thank Dr. Thaneja and his team for inviting me for this oration. And I'm extremely sorry I cannot join you physically because of my personal reasons. I'll start sharing my screen. I'll be talking about TAMPFIC, a proposed Indian classification system for cholesteatoma. The order of my talk will be, first will be definition of cholesteatoma, history of nomenclature and theories, evolution of cholesteatoma classification, Indian classification system for cholesteatoma, TAMPFIC, and case discussions. Cholesteatoma is a benign keratinizing epithelial line cystic structure found in the middle ear and the mastoid. It can cause destruction of the local structures, ossicular chain, otic capsule, leading to complications and such as hearing loss, vestibular dysfunction, facial paralysis, and intracranial complications. What are the protocols available at present for treatment of cholesteatoma? First, we do the clinical evaluation, history taking, micro or otoendoscopic examination, proton audiometry, HRCT, or MRI temporal bone to evaluate the extent of the disease for surgical planning, to classify the disease, and goals of surgery is to total removal of the disease, essential to minimize the risk of recidivism and optimal hearing restoration. Surgical approach, microscopic or endoscopic, open or closed cavity with or without ossiculoplasty. Newer technologies compete with the established standardized surgical approaches and they need to be validated. Final goal is to evaluate and compare the outcomes of various surgical approaches by staging. Advantages of staging system, it segregates the cases based on their similarities. It helps in reporting per operative finding and surgical outcomes, standardized treatment protocols across the geographical boundaries, and require multicentric approach for validating this system to reach a common consensus for defining treatment protocols. Let's, in brief, see the history. It was first described by Duvarney in 1683, and John Miller was the first one who coined the term cholesteatoma in 1838. Rudolf Ischios, he said cholesteatoma is a tumor. Gruber, Wendt, and von Trolsch, they put forward the theories of cholesteatoma. They said it is mucosal squamous metaplasia theory in 1868. Politzer said it's a glandular neoplasm of the middle ear mucosa in 1869. And Bezold's retraction pocket theory, we all know, abdomen migration theory. Lange and Rudy, they put forward the basal cell hyperplasia theory. And congenital cholesteatoma was discovered first by the Mack and then Michaels. Evolution of cholesteatoma classification. The first attempt was made in 1964 by the Committee of Conservation of Hearing of the American Academy of Ophthalmology and Otolaryngology. They classified the surgery for chronic ear infections and considered the location and type of cholesteatoma seen during surgery. Later on, Maroff and Trulsum, they classified cholesteatoma based on its location, pathophysiology, giving consideration to eustachian tube, ossicular function, ossicular status, and complications. And limitations, absence of clinical relevance linked to the need for multiple factors to be investigated, some of which are complex in pre-operative phase. Following which, TAWS in 1988, Sanna in 1993, and by B. Black in 2011 gave classification. In 2012, Bellal gave a staging system for tympanomastoid cholesteatoma from stage 1 to stage 5 based on the site of disease in the tympanic cavity or in the mastoid cavity and the presence of any complications. Ossicular status was not taken into consideration. The limitation of this classification is complexity due to the big number of variables. Then JAWS, this is Japanese Otology Society. They classified cholesteatoma into congenital, acquired, and unclassifiable. Acquired, again, they classified into retraction pocket cholesteatoma and non-retraction pocket cholesteatoma. Then the sites they included, protympanum includes eustachian tube and supratubal recess, T for tympanic cavity, A for attic, and M for mastoid. And staging system based on the number of anatomical sites involved and the complications present. Stage 1, only one site is involved. Stage 2, 2 or more anatomical sites. Stage 3, intratemporal and or extracranial complications. Stage 4, intracranial complications. Limitations does not help us in depicting the actual extent of the disease based on staging. Example, a cochlear fistula and a facial nerve palsy share the same stage, that is stage 3, which does not convey the details of the extent of the disease. Then came the European Academy of Otology and Neurotology, and then their classification. And then they join hands with JAWS, that is Japanese Otological Staging System classification. And this is similar to the original JAWS classification. Extent of the disease was further classified based on the difficulty of assessing size. You can see JAWS PTM, whereas when they combine, we have the STAM. S for supratubal recess and S2 is for sinus tympanic. And it applies to 4 types of medullary cholesteatoma: pars flaccida, pars tensa cholesteatoma, congenital cholesteatoma, and cholesteatoma secondary to a tensor perforation. Stage 1, cholesteatoma localized in the primary site. The site of cholesteatoma origin, that is attic or pars flaccida cholesteatoma, tympanic cavity, or pars tensa congenital cholesteatoma, and cholesteatoma secondary to pars perforation. Then stage 2, cholesteatoma involving 2 or more sites. Stage 3, cholesteatoma with extracranial complications like facial palsy, labyrinthine fistula, and conditions at risk of membranous labyrinthitis. Then stage 4, cholesteatoma with intracranial complications. Then we have one more classification, Chole classification, where CH stands for cholesteatoma extension, O stands for ossicular chain status, L stands for complications, and E stands for pneumatization and ventilation, that is eustachian to function. Based on these 3 stages have been described. Now, coming to the proposed Indian classification, TAMPFIC, it's a simple grid classification system. It's based on the clinical findings, radiological finding, HRCT, and MRI, because MRI in our Indian scenario, whether it's feasible to do in all centers, we are not very clear at this point of time. And it makes it easy to represent all possible cases of cholesteatoma using single universal staging system, and can be used to represent the extent and stage of the disease once validation of this classification is done by doing studies at different centers. Helps in defining the standard treatment protocols across the world. It can also help in comparing the outcomes of different surgical approaches published in various series. It consists of preoperative grid 8x7, classifies cholesteatoma based on the involvement of anatomical sites, their subsites, destruction or erosion of the bony walls, intratemporal complications, and intracranial complications. Our operative grid 8x8 grid. Along with this, we add the intraoperative ossicular chain status. Then postoperative grid 8x9 box includes postoperative outcome of the patient. Anatomical sites considered are T for tympanum, attic, then M for mastoid, then P for protympanum. Other factors that have been used for classifying are the facial nerve and its pathology, intratemporal complications, that I, intracranial complications C, ossicular chain status O, and postoperative outcome. This is the 8x7 grid. You can see in the tympanum, mesotympanum, retrotympanum, and hypotympanum. And again, you have A and B, A, B, C, depending on the erosion of the walls. Attic, erosion of scutum, Prusac space, posterior epitympanum, anteepitympanum, then erosion of tegmen tympani, additus not patent. Mastoid involved with rough margins, then periantral mastoid air cell system, and then tegmen anti-erosion, sinus plate erosion. See, all we are covering in this. Protympanum, without erosion of the anterior bony wall, with partial destruction of the anterior bony wall. Protympanum with complete erosion of the anterior wall, without encasement of internal carotid artery. Protympanum with complete erosion of the anterior wall, with encasement of the internal carotid artery. Facial now, presence of facial palsy, whether horizontal segment or vertical segment. Like if the only vertical segment is involved, you get 3, F3, like that. If it is mastoid segment, F5, like that we write. Intertemporal complication, neck abscess, labyrinthitis, cholesteatoma involving the external artery, extending to external canal, vestibular fistula, petrositis, involving the petrous apex, cochlear fistula, mastoid fistula. Then intracranial complications, meningitis, extradural abscess, intradural abscess, subdural, brain abscess, venous thrombosis, hydrocephalus, cranial nerve palsy. And 18 to 8, this is the peroperative. For the same, we add the peroperative ossicular chain status with the malleus and stapes present, only malleus and footplate are present, only stapes, only footplate of the stapes present, fixed stapes present. And 18 to 9, we add the postoperative cavity problem, improvement in hearing, residual disease, and recurrent disease. This is at the end of 1 year. Then TAMPFIC T, I told you, T1 is mesotympanum, T2 is retrotympanum, T2A without involvement of the sinus tympanum, T2B with involvement of the sinus. So these are the various radiological features where we can see retrotympanum with sinus tympanum involvement, mesotympanum involvement of the left side. T3 hypotympanum. You can see the exposed jugular bulb is important while planning surgery. Hypotympanum involvement has been further split based on the erosion of the floor of the middle ear. T3A without erosion of the floor of the middle ear, partial erosion. T3C complete erosion. T3D complete erosion of the floor and exposed jugular bulb with compression systems. So when you classify this put across in the preoperative grade, you know what plan you can do when you are doing the surgery. A for attic is classified based on the important structures and anatomical subsets, as these subsets can be seen individually affected or spared in different cases. It has been classified as early erosion of the scutum, involvement of the Prozac space, involvement of the posterior epitympanum, the scutum erosion, then posterior epitympanum, then Prozac space. This is Prozac space. Involvement of the anterior epitympanum, erosion of the tegment tympani, obstruction of the adductus. If obstruction of the adductus is not mentioned, by default, it implies that the adductus is patent. Mastoid has been classified based on the involvement of the mastoid antrum, maintenance of the structures of the air cells, and the erosion of the bony compound disc. M1, involvement of the antrum with presence or characteristic rough cavity or honeycomb appearance. Periantral mastoid air cell system is involved. Photomastoids, erosion of the sinus plate and erosion of the tegment and erosion of the bone overlying the posterior fossa dura or the endolymphatic sac. Protympanum, P1 is without erosion of the anterior bony wall. You can see here the erosion of the carotid canal is there. With P2, partial erosion of the anterior bony wall. P3 with complete erosion of the anterior wall without encasement of the internal carotid artery. P4 with complete erosion of the anterior wall with encasement of the internal carotid artery. External canal includes special cases of external canal cholesteatoma, as those cases which are primary site as external canal have been excluded from this classification. Where a mastoid cholesteatoma causes erosion of the posterior wall of the external canal and extending to the dehiscence of the bony wall, it can be classified under the intratemporal. You can see eroding to the external canal. Facial nerve. F1, presence of facial nerve palsy, then erosion of the facial canal or exposure of the facial nerve, and F3 in vertical segment, F4 in labyrinthine segment, F5 in meatal segment, F6 in encasement of the nerve, and F7 encasement of the nerve more than 180 degrees. Intertemporal classification, all these complications, neck abscess, if it is I1, I2, I3, depending on what all complications we have, I5, I6, I7, and I8. Intracranial complications have been classified. C1, presence of meningitis, C2, extradural abscess, C3, intradural abscess, C4, subdural, C5, brain abscess, then venous thrombosis, lateral sinus thrombosis, cavernous sinus thrombosis, jugular thrombosis, C7, hydrocephalus, C8, cranial nerve palsy. If present, the number of the cranial nerve to be depicted as a subscript. How to use TAMPFIC? This is a case study. Cholesteatoma in attic region with scutum erosion, excluding the anterior epitympanum and extending to the mastoid antrum with rough cavity margins and with no complication. Erosion of the scutum comes under A1 we can put, and then antrum involved, then only Prozac space 2, then posterior epitympanum 3, and only antrum involved with rough margins M1. So we know what we need to do now, only scutum, Prozac space, posterior epitympanum and antrum. So you can do atopoantrostomy like that. You can plan your surgery beforehand. Cholesteatoma in retrotympanum involving the sinus tympani extending to the posterior epitympanum, mastoid antrum, encasing the fascia now, vertical segment, not more than 180 degree with clinically observed fascia or palsy. So we put for T, because retrotympanum was there with sinus tympanum, T2B. So we know the sinus tympani is involved here. Then posterior epitympanum, then antrum involved with, so M1 it comes. Then facial or palsy is the vertical segment. So then encasement more than less than 180 degree. If only these three are present, we could have just gone ahead. But because the facial dehiscence is there, then we need to go for the canal wall down. Like this, we can plan. This is cholesteatoma of the hypotympanum with erosion of the floor of the middle ear and compression of the jugular bulb with jugular thrombosis. So this is the representation at T3D C6C. Mesotympanum, posterior epitympanum, mastoid and extending to the external canal. T1A, A3, M2, then intracranial is I3, cholesteatoma involving the external canal. Cholesteatoma involving the protympanum with petrositis and palsy of the abduced mouth. So we can do protympanum in P1, then I5, and then C86. To conclude, the TAMPFIC proposed Indian classification system for cholesteatoma based on the clinical and radiological findings. This classification is capable of representing all possible cases of cholesteatoma, both congenital and acquired middle-ear. Hearing loss and ossicular status have been considered, and it might be considered late with evidence-based reporting in future. We like to validate this cholesteatoma classification across many centers in India for standardizing management protocols for similar cases based on evidence-based medicine. Yeah, the shortcoming is whether MRI is feasible in all centers. That is one thing we need to do, because whenever we need to do pre-operative grid, then we cannot do only with the HRCT. But to do MRI in all centers, whether it is feasible or not, so that we need to consider one. And so that's all I can find in the, and many variables are there. But when you put the grid, you have the grid with you in your hand when you're doing, when you are planning pre-operatively. It's easy. You can just shade it, because now we are all used to the technology we can do. I think it's only thing is we need to have the mindset to do it. Once again, I thank Professor Thaneja and its team for giving me this opportunity to participate in an online mode for this conference. I wish the conference all the success. And another thing is, from the Hawaii, because of the World Hearing Days Day on March 3rd, we are having March 2nd night universal talk on webinar on universal hearing screening. One is from Dr. Monish Grover and another is Dr. Abraham from Kerala. Then on March 6th evening between 6 to 8 p.m. We are having the webinar on theme, what for this conference, World Hearing Day 2022, safe listening skills. So based on that theme, we have the opinion and the talk by the stalwarts, Dr. Shelly Chedda from WHO, Dr. and Mr. Mark and Dr. Arun Agarwal will be joining us. Please do join us, and we'll be posting the link shortly. Thank you. I'll stop my